Good evening, everyone. I am going to talk about the use of toric IOL in keratoconus with cataract patients. So the magnitude of astigmatism in keratoconus eyes can be quite prominent and high. Eyes with keratoconus may have significant regular or irregular astigmatism. So toric IOLs are beneficial in those eyes with high preoperative regular corneal astigmatism. And assessment of progression of the disease is very important before we consider for a toric IOL. So there are various case series available in the literature. I am showing two case series with maximum number of eyes. So the first one is by Erica Fernandez Munoz et al. It was a retrospective case series. They took 54 eyes with keratoconus with cataract, and they showed that toric IOL showed good predictability in mild to moderate and stable keratoconus, in which K value was less than 55. And the second study was by Kamia et al. It was a prospective case series. They included 90 eyes with mild keratoconus. They also concluded that toric IOL implantation effectively reduced refractive astigmatism without significant induction of corneal higher order aberration. So toric IOLs have been widely used for stable keratoconus, showing documented improvement in uncorrected distance visual acuity, corrected distance visual acuity, reduced spherical equivalent, and decreased preoperative cylinders. Patient with mild irregular astigmatism that improves with refraction and has topographic and refractive stability for a minimum of 1 year before planning surgery can be considered for toric IOL implantation. Advanced keratoconus are not a suitable case for toric IOL because of their significant irregular corneal astigmatism present in these eyes. Also, keratoconus patients may have sometimes axial length more than 25 and wide to wide more than 12.5. In these patients, we should consider a CTR so that IOL does not rotate post-operatively. So this is the treatment algorithm in keratoconus patient with cataract by Nicholas et al. This so that patient having history of good CDVA and manifest axis equal to topographic axial, these patient can be go for cataract surgery with toric IOL implantation. Now coming to the debate over RGP versus toric IOL. Cost is one of the important factor. As we know, India is still a developing country. High cost of these RGP lenses can be a very important factor in considering this RGP lenses, as most of the lenses cost around 20 to 30 years, and they may be suitable for use only for 2 to 3 years. So most of the patient coming from the rural background, they may having dust allergy and everything. Maintenance of RGP lenses is also very challenging in these patients. And also one important thing, these contact lenses are not covered by the insurance company, so it will also lead to an economic burden on these patients. So using contact lens is also not free of side effects. Side effects of using contact lens such as concretions, blepharotosis, allergy with contact lens preservative and solutions, allergic conjunctivitis, superior limbic keratoconjunctivitis, giant papillary conjunctivitis, and infections. These are the most important side effects of using contact lens. So RGP versus toric, most of the patients of keratoconus had some form of allergy going in their eyes. Some studies show that almost 50% of cases of keratoconus in India are associated with VKC. These patients are extremely and highly intolerable to RGP contact lenses. So this is the one of the more important study, CLEC study. This study showed that 53% of patients of keratoconus have some form of allergy and have history of some form of atopy. This study also showed that there is 62% increase in an eye's risk of scarring if that eye wears a rigid contact lens compared to those eyes that did not wear rigid contact lenses. Nowadays, customized toric lenses are also available that can correct astigmatism up to 10 to 12 diopter. Reddy et al. Showed significant reduction in the cylinder by using customized toric IOLs in 4 keratoconus eyes. This is the small video showing customized toric IOL. This lens is available by Care Group. No financial interest involved. So now coming to the point where toric IOL should not be considered. So toric IOL should not be considered in progressive disease, difficult refraction, high difference between preoperative RGP lens corrected visual acuity and spectacle corrected visual acuity. And those patients with advanced keratoconus who may undergo keratoplasty in the future, these are not the ideal candidate for toric IOL implantation. So now take home message from this presentation is toric IOL is a good option in keratoconus with cataract. If there is a patient is having history of ocular allergy, non-compliance with contact lens use, socioeconomic limitation such as cost factor, and mild to moderate stable keratoconus. In this patient, we can use toric IOL if we are planning for cataract surgery. Thank you.
Thank you, Dr. Vishal and Dr. Reena. So expert opinion from Dr. Sharon. Right, great talks, both of you, and they're very, very nicely put together cohesively where you should or should not do a toric IOL in KC, and my job is just to bring it into perspective. So the first thing, and very easily, we are talking about aberrations, we're talking about irregular astigmatism, so many things where a toric IOL may not be the best. And one thing which you see on your topography, if you see a cone which is very, very highly decentered, okay, then that is a case where you would not want to put in a toric IOL, because very often they will not have that good spectacle corrected vision. Now you will say these patients have cataract, we don't know what is their best spectacle corrected vision because the cataract is there. You can ask the patient how their vision was before they developed the cataract, and they'll know there was a drop in vision, right? So you can ask them how their vision was. And very often, and we've all seen these patients who have lived their entire life with a keratoconus or a PMD and never realized it and come with the cataract. So in those, we are not going to be overly aggressive and trying to, bring them to a 6x6. We are trying to give them what they have lived with and what they are comfortable with. Another thing is, it's great. I am a big proponent of using contact lenses of all kinds, and what you showed were predominantly scleral lenses and RGPs. But believe me, it is not that easy for a person who is an elderly person to suddenly start using a contact lens. It takes a lot of dexterity, especially the scleral lenses, which have to be put in with a plunger and liquid. So someone who has never used contact lenses all their life will not suddenly get used to putting in a contact lens after a cataract surgery. So you have to keep that as a consideration as well. If you think that they may be, or at least they are open to the idea of putting a contact lens post-surgery, then it is good to do a trial of the fitting. Obviously, you cannot improve their vision, but you can do the trial of the fitting and see if they can actually manage that or they think they can manage it before the surgery itself, so that you can counsel them appropriately. Don't do the surgery and then say, up to, there's nothing we can do, now you have to put contact lens. That doesn't work, because we have to put ourselves in the patient's shoes and give them a holistic idea of what is possible. So counseling, as with most of these very complicated situations, is important. It is our job to give them all the options, but give them a perspective on the different options as well. The conclusion slides of both were great, because you sort of summed up where you want to do what. And definitely anything which is a more moderate to advanced keratoconus with highly irregular cornea, irregular astigmatism, highly aberrated cornea are not cases where you want to put in a toric IOL, just because their outcomes may not be optimal. And you cannot really promise them, that outcome may be, there may be a variation in what outcome you expect. Costing, you have to keep in mind, scleral lenses are sometimes more expensive than the cataract surgery itself. So again, if you're counseling for a contact lens, you have to give them, explain to them about that cost as well. But I think overall, great presentations from both.
Thank you so much, Dr. Shah.